Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. I hope you're all keeping well and safe. Thank you for tuning into my latest procedure. The patient in this video attended with bilateral. So when we say bilateral, we mean both ears. Soft occluding, so the word occluding means it's the wax is creating almost an airtight seal, so it's all the way around the edge periphery of the ear canal. Earwax. We just started off with the left ear. I initially used an ear hook because there's a bit of an opening at the top. I inserted the ear hook into the main body of the wax, however it just dissected it. It didn't move it forward to extract it. So because I've created a bit of more of a wider opening, because the wax is a bit soft, I've decided to now use a curette, also known as a Jobson horn. I managed to get a bit more wax out, however, there's still a large quantity, significant amount of wax still in the ear, and it just didn't feel right. Something called kinesthetic feel. So kinesthetic feel is, you actually get this feeling when you're doing the procedure in your hands, and you can sometimes see it as well, but you get this kind of, it's almost like a gut feeling, and you get that gut feeling through the sense of your fingers, your arms in the ear, the consistency of the wax. It's not something you can visualize over a screen. So I've decided to use a zonal suction probe now. So it's just past probably the first centimetre of the ear canal. We know we're more lateral near the entrance because of the hairs. Patient did have a few hairs on both sides. But these hairs are only found on the outer third of the ear canal, the cartilaginous portion. That's where the hair follicles are. You shouldn't really find any hair follicles in the inner 2/3 of the ear canal, because the inner 2/3 of the ear canal, it's a very thin layer of skin, less than 0.1 millimeters of thickness, tightly adhered to the temporal bones. The temporal bone is the bone that encompasses the ear canal, and there shouldn't be any hair fibers here. So I'm just on the posterior canal wall. You just saw what I did there. I just released this plug of wax and the skin that was attached to it off the posterior canal wall. And that frees up, it mobilizes this plug of wax, and I'm just trying to wriggle it through. We have two bends in the ear. This patient's second bend is quite prominent, so I'm just trying to navigate this around the second bend. And within the ear canal itself, you get narrowings and widenings. And again, when we remove wax, it's not as simple as just putting a suction probe into the ear and pulling something out. You have to navigate the bends, the narrowings, the widenings. So this plug of wax is a bit more medial, it's a bit sticky, so it's quite a stubborn consistency of wax. And you can see I was rolling it initially, bringing it past that second bend, bringing it forwards, and now I'm trying to wriggle it through the entrance. Near the entrance, about between half a centimetre up to a centimetre, we have an area called an isthmus. So an isthmus just means a narrowing, and we have two isthmuses in the ear canal. We have one where the cartilaginous part of the ear canal, so the outer third, and the inner 2/3, the bony, the osseous part, the juncture. Where the osseo-cartilaginous juncture is, when the bone and the cartilage make contact, we get a natural narrowing there, and then we also get a second narrowing about 1/2 centimetre away from the eardrum. So we're just on the right side, and again, patients, we're quite lateral here. Whenever you see hairs like this, you know we're near the entrance, so that's a good indicator. Plug of wax is a bit more stubborn on this side. It's a bit sticky, gooey, just like the other side, and I'm just trying to elevate the outer rim of the plug of wax, where there's skin, off the canal wall. I'm trying to detach it. So this plug of wax is encompassed with a layer of keratin, dead skin. And this skin can act like double-sided sticky tape. Not only does it stick to the ear canal wall, it also sticks to the plug of wax. I'm just trying to mobilize it. And because this plug of wax is extending all the way to the patient's eardrum, so almost 2.5 centimetres in length, it's also trapped within the isthmus. If you remember before, I explained there's two narrowings, two isthmuses in the ear canal, one about 1 centimetre into the ear canal where the bony part and the cartilaginous part of the ear canal meet, and the second narrowing is 1/2 centimetre away from the eardrum. And this plug of wax is stuck in the narrowing, so we have to put a bit of force bringing it forward. So I've just put an ear hook in here. So again, the ear hook, it did take a bit more wax out than the left ear, but because of the consistency of the wax, it just sliced through. You can see that mark actually. It's like a hot knife through butter. So I've just gone back in with the zonal suction probe, and I'm just elevating this wax off the base of the ear canal wall, and and off also the anterior canal wall. So the anterior canal wall is the front part of the ear canal. So in the case of the right ear, the anterior canal will be the right hand side of the ear canal, and the posterior, the back part of the ear canal, will be the left hand side of the ear canal, and vice versa for the left ear. So in the left ear, the anterior canal wall, the front part of the ear canal, is the left side, and the posterior canal wall will be the right side. So you can see I'm just gently lifting this plug of wax up in small delicate motions. Quite often when we're training people to perform earwax removal, they've got a tendency of just really smacking this suction probe right up against the wax, and all you do is clog it. So it's almost a case of kissing the surface. You can see I'm making these fine brush strokes movements, trying to lift, elevate the wax, and it's also a lot more gentle for the patient. We've got this remaining residual plug of wax. It's quite sticky. I was contemplating putting some olive oil earwax drops at this stage just to loosen this, but again, I'm referring back to that kinesthetic feel. I just felt doing the procedure that this was going to come out if I'm gentle, and again, I've just got to avoid that anterior canal wall. This is the anterior recess. So just going back to the isthmus, we have a natural narrowing about 0.5 centimetre away from the eardrum, and then the ear canal protrudes back outwards again. That creates recesses. We normally get 2 recesses. We get one anteriorly, so the front part of the ear canal, where the ear canal, it narrows and it widens and it protrudes to the right, and sometimes we get an inferior recess, so at the base of the ear canal near the eardrum. It's like a trench there, and it's probably one of the most hardest areas to remove earwax. Fortunately, with an endoscope, we're privileged to have the view of it. Sometimes with an otoscope or a microscope, the view of the anterior recess may be restricted, but with an endoscope and with an endoscopic approach, it just gives you a wider field of view. And you can see at the moment I'm just working the inferior recess. I just lifted the wax up and then to the left away from the anterior recess, and there's the patient's eardrum, all intact. Slightly red because the ear canal, the wax was really embedded, it was compacted. That's all the remnants of both ears. You can see it's like a clay soft type consistency, a bit like wet mud. I actually weighed this wax and it just came in over 0.5 gram, so 510 milligrams. I hope you enjoyed that video, guys. If it's the first time you're watching on YouTube, please do feel to subscribe to the channel if you enjoyed it. Select the bell icon so you'll get notified as and when I upload new videos. And if you're watching on Facebook and Instagram, similarly, please do follow the page. Take care, guys. Bye.